morning friends, we are going to discuss FMGE January 2024 questions in this session. There are around 40 questions asked from surgery and allied subjects. So we are going to discuss around 40 questions in this module. So let us see. All the following are seen in refeeding syndrome except. So I hope you all would have read, it's a repeat question, refeeding syndrome. So refeeding syndrome, all of the following are seen except hypophosphatemia, hypokalemia, hyperkalemia, hypocalcemia. So please understand, in patients who are on TPN following a malnourishment, for example, he has undergone some surgery and we started a TPN for a patient who has not taken any food for past few days. Such patients, what happens? TPN contains glucose. So what happens? This glucose will stimulate insulin. Insulin is produced in excess and the function of insulin now is to drive the potassium into the cells. It drives the potassium into the cells. That's the function of insulin. It drives potassium into the cells. Therefore, there is hypokalemia. So, therefore, there is hypokalemia and hypokalemia induced arrhythmia and congestive cardiac failure can happen. So, hypokalemia, arrhythmia and congestive cardiac failure will happen because of this massive electrolyte shift of potassium. Similar to potassium, there are so many other electrolytes also shift from extracellular to intracellular. They are given by a mnemonic PCM. So, there is a shift of phosphate, calcium and magnesium. So, hypophosphatemia, hypocalcemia, hypomagnesemia. So, all these are seen in those patients. So, what are all the other electrolytes which are lost means there is also loss of hypophosphatemia, hypocalcemia, hypomagnesemia. So, 3 more electrolytes are lost: phosphate, calcium, magnesium. So, 3 more electrolytes are lost. Therefore, refeeding syndrome is characterized by hypokalemia, phosphatemia, calcemia, magnesemia. So, which is not seen here is, please understand, it's a repeat MCQ, hyperkalemia. So, this question is already asked in the exam. So, it's a repeat easy question in this exam. So, now a patient is diagnosed with a squamous cell cancer of the skin, which is not involving the lymph nodes. So, squamous cell cancer of the skin, they didn't mention which place. So, let us assume it is a squamous cell cancer somewhere in the upper limb. They have not mentioned where is it. So, let us assume this is a squamous cell cancer in the upper limb. So, what will I do for this squamous cell cancer? So, please remember, for basal cell cancer and squamous cell cancer, margin clearance given is 4 to 6 millimeters. For a skin cancer, margin clearance given on all 3 dimensions is 4 to 6 millimeters for basal cell cancer and squamous cell cancer. When it is a melanoma, it is a malignant melanoma, the margin clearance given is 1 to 2 centimeter. Margin is given on all the 3 dimensions. So, accordingly, this patient I will give a 4 to 6 millimeters and I removed the tumor. In all the 3 dimensions, I have given 4 to 6 millimeters and I have removed the tumors. Now, how will I close this defect? Please understand, the defect is about to be closed. So, if it is about to be closed, it is easily closed with the help of skin grafting. So, skin grafting is enough. So, if it is in some other place except face, if it is in the face, if the same clearance is done in the face, I will try to do a full thickness graft because it is cosmetically good. So, if it is done in the face, I will do a full thickness graft. If it is done in the peripheries or other places, I will go for a partial thickness graft. So, don't forget, I will go for a partial thickness graft. So, this is enough. So, please understand, many students might have answered as wide local excision with the flap repair. See, flap repair, what is the indication of flap? It's just a wide local. Actually, the correct answer is skin grafting with wide local excision. That should be the correct answer. So, I don't know whether the recall had a wide local excision with the skin grafting. So, ideal answer is D, a wide local excision with the skin grafting. So, the point here you should not forget is flaps are not needed. Flaps will be used in places where there is a no blood supply. Used on bones, tendon or any composite defect. Only in these places we use flap. Otherwise, we can use the skin graft itself. That is enough. Just a simple skin graft is enough in most of the places. Flaps are used only in bones, tendons and composite defect areas. Please don't forget this basic point. And second question is a simple easy question for your exam. Third question, patient after road traffic accident was brought to emergency. His pulse rate is 50 per minute. See, pulse rate is decreased. Okay, very important. BP is 80 by 60. So, blood pressure is decreased. On evaluation, his ECG is normal and E-fast is normal. X-ray chest is normal. So, all these points are given to say you E-fast normal, X-ray chest normal means there is no bleeding inside. So, there is no chances of hemorrhagic shock. That is what the examiner wants to make you clear. So, no chances of hemorrhagic shock from these 2 points. And ECG normal, it implies there is no cardiogenic shock. There is no evidence of cardiogenic shock. That is why ECG is also normal. So, most important point here is usually in cardiogenic shock, hemorrhagic shock, there will be increased pulse rate and decreased BP. Please don't forget, there will be increased pulse rate and decreased BP in hemorrhagic as well as cardiogenic shock. The only shock where you have hypotension with the bradycardia is a repeat question, last year NEET PG question. So, it is neurogenic shock. So, neurogenic shock is a shock where there is decreased pulse rate and hypotension. So, bradycardia with hypotension. Bradycardia plus hypotension is seen in neurogenic shock. So, don't forget this point. So, bradycardia with hypotension is seen in neurogenic shock. So, the answer is C. Simple question. A patient was brought to emergency after RTA. He was wearing a signs of seat belt abdominal trauma was present. So, seat belt injury. So, the concept is related to seat belt injury. In a seat belt injury, patient now has guarding and rigidity on examination of the abdomen. What should be considered, what injury is considered in this patient? So, can you tell me what is the most common organ injured in seat belt injury? It is mesentery. Please don't forget, it is mesentery. See, for example, this is a bowel and this is the mesentery. This is the mesentery. You all know very well, the blood vessels to the bowel are running through the mesentery like this. If there is a laceration like this horizontally, what will happen? Horizontal laceration will damage the blood flow to the bowel and this bowel will develop gangrene. And this can go for gangrene and perforation. So, gangrene and perforation can happen in mesenteric tear. So, this patient therefore had a hollow viscous injury. That is why there is classical finding known as guarding and rigidity. Guarding rigidity is seen in hollow viscous injury. Hollow viscous injury is not a direct viscous injury. It is usually due to mesenteric injury causing loss of blood supply to the bowel. Okay. Most common organ injured is mesentery. Second common organ injured is DJ flexure of bowel. So, DJ flexure of bowel can also directly get perforated. So, both injuries, whatever it is, both mesenteric injury or a direct bowel injury, there is leaking of the contents which is going for guarding and rigidity. So, don't forget, this is a simple question asking you about what is the common organ injured in this list. Okay, this is a classical finding of hollow viscous injury in a mesenteric tear. So, mesenteric tear can be longitudinal or transverse, which is dangerous. Longitudinal tear or transverse tear. So, longitudinal tear is less dangerous. For example, if it's a tear like this, usually the blood supply is maintained, so it is less dangerous, whereas transverse tear is more dangerous. It's a Ames question. So, in a mesenteric tear, which tear is dangerous means it is transverse tear which is more dangerous. Please don't forget this point. Okay, this is a very important point for your exam. So, and every year we see this question, following image on CT scan is suggestive of dash. Following image on CT scan is suggestive of what? Hemorrhage. So, this is a picture showing you there are 3 types of hemorrhages we commonly see in CT scan: EDH, SDH, SAH. So, EDH due to middle meningeal artery injury, SDH due to bridging vein injury, bridging veins injury. Subarachnoid hemorrhage is due to bleeding into the subarachnoid space. There is a bleeding into the subarachnoid space. Subarachnoid space is having blood collection. So, when you do a lumbar puncture in these cases, you can get a xanthochromic CSF. xanthochromic CSF is seen in subarachnoid hemorrhage due to bleeding into the CSF collection area. So therefore, subarachnoid space is having hemorrhage. So this is a classical 3 cases. In this, EDH will have a biconvex hemorrhage like this. EDH has a biconvex hematoma. Repeat MCQ. Biconvex hematoma is seen in EDH. Concavo-convex as shown in the image. So this is concavo-convex seen in acute SDH. It is concavo-convex. See, acute SDH is usually due to severe high velocity injury. High velocity injury in which there is an acceleration and deceleration. There is an injury where there is acceleration plus deceleration happened. So high velocity injury with acceleration, deceleration is called as acute SDH. So don't forget this acute SDH. Biconvex EDH is usually due to fracture of pterion bone. Fracture of pterion bone, which is the thinnest bone. So any injury in the skull usually causes fracture in the pterion part of temporal bone and it causes collection of blood inside. So EDH is due to fracture of pterion. SDH is due to high velocity acceleration and deceleration injury. So don't forget this is a concavo-convex. So the answer is subdural hematoma. So this is a very common question. Every year they ask you an X-ray chest question from surgery or from radiology. So a 15-year-old boy, which is the most likely pathology in the X-ray given in the picture below. So this is an X-ray. In this X-ray, you are seeing there is a haziness of the right lung. So right lung is not seen. The right side there is haziness of right lung. And in this picture, if you very closely observe, you can see the trachea is shifted to the right side. So this is probably due to some foreign body causing obstruction of this bronchus. Right bronchus is having an obstruction. Therefore, probably what happened? This side lung got atelectasis. So that is a classical picture. So this is a picture of right lung atelectasis. Right lung atelectasis. So there are 3 more pictures I want you to understand in X-ray chest. X-ray chest showing haziness on the right side. Number 1, this is a picture showing you atelectasis. In atelectasis, there is right side haziness. There is trachea shifted to same side. This is atelectasis. The third picture, closely observe, there is a tracheal shift to the opposite side. Tracheal shift is to the opposite side and same haziness is present. What is the cause? So trachea shifted to opposite side. So trachea to opposite side with the picture of X-ray showing haziness of the right side. This is a classical finding of hemothorax. Hemothorax. Following a trauma, there is a collection of blood that shifts the lung to the shifts the mediastinum to the opposite side. So there is trachea shifted to opposite side. And this haziness here with the trachea in the midline. You can see the trachea in midline. So trachea in midline trachea. This is usually a collection of fluid known as usually pleural effusion. So moderate pleural effusions, you can see the S-shaped curve of Ellie's. You would have read in medicine, you will see a S-shaped curve of Ellie's. Ellie's curve will be present in pleural effusion. So trachea is going to decide the haziness. If it is trachea deviated to the same side, it is atelectasis. Opposite side is hemothorax. In the midline, it is pleural effusion. So classical picture of these 3 diseases. This question is showing you a lung atelectasis due to lung collapse. Okay, due to some foreign body. A patient presented to hospital complaining that on walking a certain distance, he felt pain in his calf, because of which he cannot walk any further distance and has to take rest as per Boyd's grading. So Boyd's classification of claudication pain. This is a simple question on Boyd's grading of claudication pain. It is a question on claudication pain. Boyd's classification of claudication pain. So please understand there are 4 grades. Grade 1. A patient starts walking. He gets pain, walks with the pain and pain disappears. It is called as disappearing pain. He gets a pain, it disappears after walking for some distance due to substance P which accumulated is washed out. So substance P is washed out, that is grade 1. Grade 2, the patient starts walking, he gets a pain, he walks with a limp. He walks with a limp, that is known as limping pain. But he completes his job. He completes his job by walking with a limp. Grade 3 is a patient who starts walking, he gets pain and it makes him sit. It compels him to rest. So, compelling to rest. Compelling to rest is grade 3. On rest, pain disappears. So, now pain disappears. As the patient takes rest, pain disappears. Okay, that is very important. Grade 4 is a person who is having pain even when he is simply lying down. So, that is known as rest pain. Not doing any job, he is just lying down. He is having pain. Usually, these type of grade 4 patients will take an attitude of sitting with the legs down. So, they will be lying in such a way, they will be putting the legs down. So, hanging down legs can be noted. So, hanging down legs are noted in grade 4. So, grade 4 is complete rest pain. So, now in this question, a patient has a pain, he felt pain in his calf region, because of which he cannot walk any further and has to take rest. So, therefore, it is not rest pain. He is taking rest, therefore, it is grade 3 cases. This is Boyd's grading of claudication pain in peripheral vascular disease. It is a topic of peripheral vascular disease. Okay, please don't forget this cause. Peripheral vascular disease getting pain. A patient is on bed rest after cholecystectomy. She developed fever and respiratory distress 3 days later. Which of the following patient's pathology best explains the patient's condition? So, this is a classical patient status post-surgery. Patient following a surgery is in bed rest. A patient following surgery going for bed rest develops what problem? Patient develops DVT. It is usually seen on 4th post-op day. Usual cause of fever on 4th post-op day is DVT. They will be characterized by only fever and pain. But in this case, there is a clear symptom showing you breathlessness, which is a feature of pulmonary embolism. Pulmonary embolism is a feature of breathlessness. Please don't forget, there is a feature showing you breathlessness. So, classical feature of DVT and pulmonary embolism are shown here. So, this patient underwent surgery, go for DVT and develops pulmonary embolism. The classical answer here is, which is the best pathology here is pulmonary embolism. So, pulmonary embolism manifests as breathlessness, and you would have been reading more points about pulmonary embolism in medicine books. Okay. So, this is mostly a surgical and pathology question. 24-year-old girl presented to OPD with a 2 into 3 centimeter mobile firm rubbery lump in the breast. Histopathological examination is given below. What is the common diagnosis? So, I'm not worried about the histopathological appearance, because as a surgeon I don't know to read pathological features, but this is a lobulated appearance on pathology. But classical feature of Indian rubbery consistency in a mobile lump. Indian rubbery consistency of a mobile lump called as breast mouse. Breast mouse is a feature of fibroadenoma. Please remember, there are many updates in 28th edition. Fibroadenoma, 28th edition says it falls under what? Birat's grading. It is Birat's 2 lesion. So, it is Birat's 2 lesion. No need of biopsy or surgery. No need of any biopsy or even surgery is not needed for these patients. So, fibroadenoma comes under Birat's 2, no need to go for surgery. So, when will I operate fibroadenoma? Very important indications. So, when the age is above 35 years, okay, when the age is above 35 years, or when the fibroadenoma is more than 5 centimeter, or if you have suspected mammography findings. So, mammography findings are not conclusive of Birat's 2, you are still having a doubt, it can be a malignancy. So, above 35 years, more than 5 centimeters, suspected mammography findings, and patient wants to do surgery. So, only in these 4 cases I will advise surgery. Surgery is done for the following 4 indications: more than 35 years, more than 5 centimeter, suspected mammography, and patients want surgery is a reason for operating a fibroadenoma. Otherwise, fibroadenoma, no need of any surgery. And you all know the basic MCQ, fibroadenoma on mammography shows what? Calcification. Popcorn-like calcification. Don't forget, popcorn calcification is seen on mammography. It's a repeat MCQ, old MCQ. So there are many clinical questions. They are not going for one-liners like olden days. A patient presented to surgical department with a slowly increasing swelling in front and below the ear and lifting the ear lobule. Which of the following surgery is most likely done? So this is a classical clinical feature of parotid tumor. Parotid tumors, what are the features? Number one, they lift ear lobule. Number one. Then, what other features are seen? They lift ear lobule, they obliterate retromandibular groove. Obliterate retromandibular groove. Number three, they have curtain sign positive. Curtain sign means I can move the swelling side to side, but I cannot move above the zygomatic bone. That is known as, like a curtain, I can move side to side. That is known as curtain sign positive. Lift the ear lobule, obliterate retromandibular groove, and curtain sign positive are the features of parotid tumors. 27th edition Bailey. 27th edition Bailey says, for benign parotid tumors, if it is a benign parotid tumor, the treatment done for such cases is superficial parotidectomy. So this is from 27th edition Bailey. But 28th edition Bailey has updated some interesting points. That is why I am having a doubt whether this is a proper recall by the students, because which of the following surgery is most likely done in this patient? There are very interesting points like superficial parotidectomy, enucleation, wide excision with a primary repair. So wide excision with a reconstruction, like that many points are added. New Bailey is giving now conservative parotidectomy is advised. Conservative parotidectomy is new update. If it is from 28th edition, please remember, we can give an adequate margin and resect the tumor. So it's with a good margin. If it is a benign tumor like pleomorphic adenoma or Warthin's tumor, you can do excision of the tumor. Excision with adequate margin is enough. That's a new update. So whether there is a choice like this given in this exam or not, I don't know. But please remember, there is a new change in benign tumors of parotid. Benign tumors of parotid, 27th edition was mentioning as superficial parotidectomy, but new edition is mentioning as conservative parotidectomy with adequate margin excision. The major advantage of this conservative parotidectomy is nerve injury is less, is avoided. So otherwise, most commonly the facial nerve branches are injured. In conservative parotidectomy, we can limited resection of the tumor helps us to prevent injury of the various branches. So please remember, this is a new update. But as of now, this question from these choices, I will go for superficial parotidectomy. In future, if you get a question on parotid tumors, remember this conservative parotidectomy in your mind. So identify the following image shown here. Though this is a classical image showing you there is an ulcer in the face. Ulcer in the face with a rolled out margin. See, this is a picture showing you ulcer with a rolled out edges. Where will you get rolled out ulcer? Rolled out ulcer is basal cell cancer. Rolled out edges are seen in basal cell cancer. Where you will get everted edges? In squamous cell cancer, you get an everted edges. Where will you get an undermined ulcer like this? Undermined ulcer is seen in TB. Please don't forget, where will you get punched out ulcer like this? In syphilis. Syphilis, you get punched out ulcer. Syphilis and arterial ulcers are punched out. Where will you get sloping edge like this? Sloping edge. Sloping edge is seen in venous ulcer. See, very simple concept. So this is a picture showing you rolled out and beaded edges of basal cell cancer in the face. Simple question, okay? Punched out in syphilis, everted edge in squamous cell, sloping edge in venous ulcer. It's a repeat MCQ. It's a basic second MBBS level question. So please don't make mistake in this. In RTA, patient presented with a crushed limb after trauma. As a result of crushed limb, myonecrosis, amputation, crushing injury and myonecrosis, amputation was performed for the patient. 3 days later, he comes to you with redness and swelling over the site, and examination shows there is soft tissue necrosis and crepitus, most likely diagnosis of this patient. So you all will be very clear. There are two important infections we should not forget. One is gas gangrene. So gas gangrene is a very common microbiology question caused by Clostridium organism, whereas there is another one known as necrotizing fasciitis. necrotizing fasciitis is caused by beta hemolytic streptococci initially, but later it becomes polymicrobial. Many organisms are involved in necrotizing fasciitis. Very important point I want to tell you here is gas gangrene has history of trauma, and patient is not immunocompromised patient. Patient is not immunocompromised patient. He has had a nasty trauma, that's all. He is not immunocompromised. He had a nasty trauma, very bad injury that has gone for entry of the soil. The 𝗁𝗂𝗯𝗀𝗀 Clostridium enters the wound. That is Clostridium causing gas gangrene. Whereas necrotizing fasciitis is always seen in immunocompromised patients. It happens spontaneously. There is no specific history of any injury. So there is spontaneously it can happen. Necrotizing fasciitis can happen spontaneously. So gas gangrene on examination will have crepitus. Necrotizing fasciitis on examination will have skin gangrene, dish water pus coming out, will be coming out from this necrotizing fasciitis. It is a rapidly spreading subcutaneous infection. Please remember, it is rapidly spreading infection, necrotizing fasciitis. So what should I do for this gas gangrene? Gas gangrene patients, immediately I should do anti-gas gangrene serum. Very high mortality. Please remember, anti-gas gangrene serum is given. Serum immunoglobulin is given for these patients, and we have to give hyperbaric oxygen. So hyperbaric oxygen and anti-gas gangrene serum is given for these patients. Whereas for necrotizing fasciitis, we should do debridement, extensive debridement of the necrotic tissues. Extensive debridement is done. So this patient is having crepitus, so I will go with gas gangrene. So don't forget gas gangrene and necrotizing fasciitis. Which of the following have maximum chances of graft versus host disease? There are two types of rejections you should not forget. One is graft rejection. Okay, graft rejection. For example, this is Mr. Ramu who had an organ from Mr. Somu. The organ received by Ramu is a kidney. Okay, he is having a kidney now. He is having one kidney received from Somu. So this kidney is a foreign organ for Ramu. So what will this kidney do? So this kidney is now a foreign organ. Therefore, Ramu's body will produce T lymphocytes. T lymphocytes are produced by this guy, and they are known as cell-mediated immunity. Cell-mediated immunity. It is an immunity in our body. When something foreign body comes to our body will fight against it. So therefore, as a part of cell-mediated immunity, we are fighting against this kidney. So that is by releasing interleukin-2 is released in enormous amount, and that will go and reject this kidney. So that will go and reject this kidney. This kidney, I don't want this kidney. This is Somu's kidney, I don't want. So it will reject. So this interleukin-2 released and rejection of this kidney is known as graft rejection. It can be easily cured by immunosuppressants. If I give immunosuppressants like cyclosporin, tacrolimus, etc., this interleukin-2 will be inhibited and there is no organ rejection. So this organ rejection is seen in kidney very commonly. So there is another disease. This question is not asking about this. The question is asking graft versus host disease. Here Ramu received an organ from Mr. Somu. The organ he received is not kidney, but he received a small bowel. For example, this is a small bowel he received, small bowel transplant. Understand a very important point. Small bowel is having so many lymphocytes. Small bowel is having so many lymphocytes and antibodies. So this graft which is kept inside will now reject Ramu. So this is huge amount of lymphocytes. So this will reject Ramu. This is called as graft rejecting the host. So this is known as GVHD. It is most commonly seen in small bowel because of the extensive lymphatic seen in small bowel. So please understand the answer is intestine. So the huge amount of lymphocytes present in the small bowel like pus, patches, etc. will reject the graft, is going to reject the host. If host rejects the graft, it is graft rejection, which is common phenomenon. It is more common phenomenon. Very, very rare is graft itself rejecting the host. Is very, very, very rare phenomenon. So GVHD, the only option is we have to remove the graft. We have to remove the graft. Sometimes we need to remove the graft. Sometimes we have to decrease the immunosuppressants. Many treatments are there, but it is beyond the level of FMG exam. Just remember, GVHD is common in small bowel. This is a carry home MCQ for lifetime. Okay. A newborn baby was having difficulty in breathing, and on evaluation there are multiple air fluid levels in the left hemithorax. What will be the most likely diagnosis? See, for your exam, I want to tell you 4 baby questions will come very commonly. Newborn baby questions. One is tracheoesophageal fistula. Another is congenital diaphragmatic hernia. Another is meconium ileus. Newborn cases, meconium ileus. Another is what? Meconium ileus, and another one is midgut volvulus. 4 emergency cases. 4 emergency cases in a newborn baby. Please remember, 4 emergency cases in a newborn baby. The history is very clear. Tracheoesophageal fistula, a newborn baby will have drooling saliva. When I pass the Rayleigh tube through the nose, the Rayleigh tube is coiling of Rayleigh tube seen. Okay, simple question. That is tracheoesophageal fistula. Congenital diaphragmatic hernia, the patients will have breathlessness. When I give bag and mask, there will be more breathlessness. Please don't forget, when I am going to give bag and mask, it will cause more breathlessness. So, breathlessness, bag and mask aggravates the breathlessness. And when I take an X-ray, X-ray shows Bogdalak hernia, left side will have multiple bowel loops. X-ray shows left side bowel loops. Meconium ileus is seen in babies with the cystic fibrosis. Cystic fibrosis baby, they never pass meconium for more than 48 hours. Meconium is not passed. So when I see the baby, they having abdomen distension. When I take an X-ray abdomen, please understand there is no air fluid level. That is because there is no fluid at all. That is a dry meconium. So no air fluid level seen in X-ray abdomen. That is a very important point in meconium ileus. Meconium ileus. Thick, dry meconium obstructs the small bowel and absorbs all the fluid which is available in a cystic fibrosis patient. They have no air fluid level. So midgut volvulus is another interesting condition in which the baby will come to you with the bilious vomiting. Very dangerous bilious vomiting. And on X-ray, on a bilious vomiting, if I take X-ray, there are multiple air fluid levels seen. In these cases, there are multiple air fluid levels seen. So, investigation of choice for this case is gastrographin study. I have to give gastrographin for the baby to swallow and take the X-ray so that I can find out the volvulus in the bowel. So, these 4 cases are very commonly asked MCQs for FMG exam. Tracheoesophageal fistula, congenital diaphragmatic hernia, meconium ileus, midgut volvulus. Don't forget this. So, what will be the most likely diagnosis in this patient with the multiple air fluid levels in left side chest is congenital diaphragmatic hernia. Okay, no confusion in this. So, 15th question is a complete new update for Bailey and Love, from Bailey and Love, new question for your exams. This question, proximal dislocation of squamo-columnar junction. I don't think this question is a proper recall. Probably they would have kept as esophagogastric junction. So, proximal dislocation of esophagogastric junction. So, let me draw you the normal anatomy of esophagus and stomach. So, this is esophagus, okay, this is OG junction and this is stomach. Please understand, the line I am making now is a OG junction, that is a OG junction, esophagogastric junction. Now, I am going to show you 2 types of hernias, 2 types of hiatus hernia. There are 4 types. I am not going to discuss everything here. If you want the full detail, you can read the regular module. In the first type, you can see the stomach is going through the hiatus like this. So, OG junction is shifted up like this. So, the stomach is going into the mediastinum like this. You can see OG junction is shifted proximally and the patients will have GRD symptoms. This is type 1 hiatus hernia called as sliding hiatus hernia. The type 1 hiatus hernia called as sliding hiatus hernia. This is type 1 hiatus hernia. So, second picture if you see here, very interesting. The OG junction is there in the abdominal cavity only. You can see the OG junction is here only. But what happened? Some part of stomach enters like this. Some part of stomach enters like this. OG junction is here. Some part of stomach entered and this is known as type 2 hernia, also known as rolling hiatus hernia or paraesophageal hernia. So, rolling or paraesophageal hernia. There are many other hernias like type 3 is mixed of both. Type 4 is massive paraesophageal hernia. Massive paraesophageal hernia. There are 4 types. So, most important point here, you should not forget this actually a repeat question of previous AIIMS exam. What is this angle known as? Angle of His. Old MCQ in AIIMS is in which of these 4 hernias angle of His is normal. Angle of His is normal in type 2 hernia. Angle of His is normal in type 2 hernia. In otherwise, angle of His is altered in all other hernias. Angle of His, you can see here, it is not altered in type 2 hernia. So, the answer here is proximal dislocation of squamous junction is seen in sliding hiatus hernia. Simple question. So, don't get confused. It's a simple question asking you about sliding hiatus hernia. The OG junction is shifted to the chest. Okay. So, this is a very important concepts you should not forget for your exams. Please don't forget. A chronic male patient presented to emergency with a sudden onset of epigastric pain radiating to the back. So, which is aggravated on lying down. So, patient is therefore leaning forward, known as Mohammed prayer sign. These are all questions which has no excuse if you have made a mistake. So, pain is aggravated on lying down. So, he will be sitting with the leaning forward. Serum amylase lipase increased. So, it is a case of acute pancreatitis. So, don't forget this history. Very classical acute pancreatitis. In case, I am giving you some scenarios. A patient has an epigastric and retrosternal pain. Epigastric and retrosternal pain radiating to the interscapula. Shooting pain to interscapular region. What is the cause? Yes, it is aortic dissection. Very good. It is aortic dissection. So, if you have answered it aortic dissection, you are excellent. You have prepared well. It is due to aortic dissection. You have pain in the central chest radiating to the interscapular region, aortic dissection. Pain in the right hypochondrium radiating to right side back. So, from here it radiates to the right side back. It is nothing but cholecystitis. So, you can get questions like this: pancreatitis, aortic dissection, cholecystitis. All these patients, there will be some clinical clues from the history. You should never make mistake in these type of questions. It's a classical question on acute pancreatitis. Please don't forget, there will be history questions related to the history. So, clinical symptom related questions will be at least 30% in surgery. So, you should understand all the disease and read, you will never make mistake. So, which of the following is the most common complication of endoscopic retrograde cholangiopancreatography? ERCP, what is a common complication? See, please understand, this is the ampulla of Vater and this is bile duct and this is pancreatic duct. So, in ERCP, I am going to use a side viewing endoscopy like this. This is a side viewing endoscopy. With the side viewing endoscopy, I am going to cannulate the ampulla and I am going to push the contrast to the bile duct and pancreatic duct, and I will study the pancreatic duct and bile duct by pushing contrast with the help of side viewing scopy. So, when I am going to push the contrast into the pancreatic duct gets irritated and gets 5% cases can develop acute pancreatitis. That is the most common complication. So, most common complication is acute pancreatitis. So, sometimes along with the ERCP, I will also do sphincterotomy. So, ERCP, I will do sphincterotomy, means I will cut the sphincter of OD. So, I will cut the sphincter of OD at 11 o'clock position, I should cut, or at 1 o'clock position. Which position will you cut is 11 o'clock or in 1 o'clock position, I should cut the sphincter of OD and I will do some procedures. For doing some procedures like for stenting or taking biopsy, I may do sphincterotomy. So, when I do ERCP plus sphincterotomy is combined, means those patients can develop with for a CBD stone. If I do it for a CBD stone, those patients can commonly develop cholangitis. Cholangitis is most common when I do a procedure. When I do only ERCP, it is pancreatitis. When I try to do some procedure, it is cholangitis and sepsis. So, this is from Bayesian law. So, when there is a procedure done, it will cause cholangitis. So, here they have mentioned only ERCP. Most common complication of ERCP is only pancreatitis. So in fact, I can reduce the incidence of pancreatitis by giving rectal suppository, rectal diclofenac suppository. If I give rectal diclofenac suppository, the incidence of pancreatitis decreases. Okay, they used to even give indomethacin, some analgesics. So NSAIDs will reduce this incidence. Incidence of acute pancreatitis following ERCP is reduced by giving NSAIDs. Okay, usually we give rectal suppository of diclofenac. A patient was diagnosed with PL2 hernia. What is the most likely hernia the patient is having? So the patient is having PL2. This is an European Hernia Society classification. So new question, but already we have discussed in our material. You can see we have discussed this concept in our classes. European Hernia Society classification of inguinal hernias. So for example, this is mentioning as PL2. What is meant by P? So P stands for primary, and if it is mentioned as R means R stands for recurrent. If it is a primary hernia or a recurrent hernia. L stands for whether the hernia is seen lateral to the inferior epigastric artery or medial to the inferior epigastric artery. L stands for lateral to inferior epigastric artery. M stands for medial to inferior epigastric artery. F stands for femoral hernia. The most important 2. 2 stands for 2 finger entering the gap. The defect 2 finger is entering. So 1 means 1 finger. 2 means 2 fingers. Each finger is 1.5 centimeter. So therefore 3 centimeter defect. So therefore this is a hernia which is primary lateral to inferior epigastric artery with the 3 centimeter defect. Lateral to inferior epigastric artery is indirect hernia. It is indirect hernia. Please don't forget it is primary. Indirect hernia is the answer. For example, if I tell PM3, what is it? It is primary direct hernia with a defect of 4.5 centimeter defect. So primary direct hernia with a 4.5 centimeter defect is called as PM3. Please don't forget this PM3. Okay, very important point for your exam. 70-year-old patient was operated with a midline laparotomy incision for adenocarcinoma. He is having a midline laparotomy. He is having operated for a midline laparotomy. He is a gap. Now there is a defect of 12 centimeter gap through which hernia is happening like this. So there is a hernia with a 12 centimeter gap is present. What should be the ideal treatment for this patient who is having a 12 centimeter gap like this? What is the ideal treatment? So there are 2 methods of treatment commonly done in practice. Either one is I will reduce the contents and I will keep a mesh like this anteriorly like this. So this is anterior approach in which open onlay mesh repair. Open onlay mesh repair. This is called as open onlay mesh repair. So another method is if this is the hernia which a bowel is going out, reduce them inside and keep a mesh from inside. So that is known as laparoscopic IPOM. What is IPOM? Intraperitoneal onlay mesh. Intraperitoneal onlay mesh is used in those cases. So that is known as IPOM. So for an incisional hernia, I can operate it from above, open technique, or we can operate it from inside and keep a mesh. So this mesh usually used here is a dual mesh. It is not pure proline mesh in which the upper part of the mesh is made up of proline. The lower part of the mesh which is facing the bowel is made up of vicryl or polyglycolic acid, and this is proline. So 2 coating, the one proline side will go to the abdominal wall and the polyglycolic acid will be coming to the outside. So this is a classical case of push the hernia back and do the mesh repair. Push the hernia back and do the mesh repair is the correct answer of this 19th question. Please don't forget. So a patient was operated for laparotomy. Patient developed a complication after operation. So following a laparotomy, he has developed a wound breakup known as burst abdomen. So that is, what is the surest sign of burst abdomen? Burst abdomen is also called as wound dehiscence. Wound dehiscence. So the first sign or the initially before the bowel comes out of the abdomen, there will be a sign known as Salmon sign. Salmon sign is sudden gush of serous fluid. sudden gush of serosanguinous fluid from the wound is known as Salmon sign. Don't forget this sign. So before the bowel is going to come out, you will have a sudden gush of fluid coming out of the bowel. Most important point for your exams. So 21st question, 3 days back urinary catheterization was done for a patient, but for some reason the catheter was taken out. Few days later he presented with the following image. This is a classical image just now we discussed, known as necrotizing fasciitis. See, necrotizing fasciitis, if it is going to happen, the patients are usually immunocompromised patients only. This patient is having a Fournier's gangrene. Fournier gangrene is a necrotizing fasciitis of scrotum. Mayrini gangrene is a necrotizing fasciitis of abdominal wall. Please don't forget, it is a necrotizing fasciitis of abdominal wall is Mayini's gangrene. Fournier gangrene is scrotum. So the immediate treatment we should do for them is extensive debridement, not simple debridement. We have to do extensive debridement. You can see the skin goes for necrosis, but the problem is the skin is only limited. The skin necrosis is up to this place, means when I go for debridement, it will be extensively spreading even to the normal looking skin area. The skin looks normal, but necrosis will be extending below. It is a rapidly spreading subcutaneous infection. Please don't forget this. There is a very interesting point. Testis is not affected. Don't forget this point. Because tunica albuginea layer is highly resistant to infection. Protects the infection entering the testis. So testis therefore goes for shameful exposure after debridement. So we have to do closure, delayed closure will be done for the shameful exposure of testis. We will be doing a delayed closure after few months. That is very important. So this is Fournier's gangrene, classical repeat question. Okay. 75-year-old male presented to OPD with a complaint of difficulty in swallowing, initially for solids and now for liquids. There is a history of significant weight loss. See, these two questions will be coming for your exams. I want you to remember, one is from 𝗂𝗽𝗱𝗁𝗂𝗃. See, from this discussion you can see many times the examiner wants to know whether you can diagnose. That's all. They are not even worried about how you are going to treat it or how you are going to investigate it. The simple question they are asking is, diagnose this disease. That's enough for me. That is what the examiner expects from you. So 𝗂𝗽𝗱𝗁𝗂𝗃 and cancer esophagus. So first of all, you should diagnose what is the two features in these cases. So please don't forget, 𝗂𝗽𝗱𝗁𝗂𝗃 is common in young females. First point. Cancer esophagus is common in old males. 𝗂�57𝗁𝗂𝗃 will have dysphagia for more than 6 months. Cancer will have dysphagia less than 6 months. In otherwise, rapid dysphagia. Here it is slow dysphagia. In 𝗂�57𝗁𝗂𝗃, there is liquid dysphagia more common than solids. Whereas in cancer, solid dysphagia is more common than liquids. Okay. So 𝗂�57 will have the classical finding of narrowing, physiological narrowing of LES. It's a physiological tight LES. It is a physiological tight LES. Therefore, if I put a solid food particle like a chicken, it will easily go inside. But a soup or a liquid one will not go inside. Whereas cancer is not like that. Cancer is a irregular thickening or growth into the lumen of the esophagus. So whatever you put initially, liquids can go between the gap, but solids will never go. They will remain above like this. So solids more than liquids is cancer. Liquids more than solids is 𝗂�57𝗁𝗂𝗃. So there is a history of significant weight loss. What is a gold standard investigation in this patient is 𝗂�57𝗁𝗂𝗃 means gold standard is high resolution manometry. In cancer esophagus, I should do endoscopy and biopsy. That is a gold standard investigation to diagnose. So for a cancer esophagus in this question, I should go for a endoscopic biopsy. That is answer for this question. Endoscopic biopsy must be done for 22nd question. So please don't get confused with the history questions. Breast cancer surgery 10 years back. Now she presented with the swelling of the upper limb with the bluish colored nodules. That's a classical clue. So a patient who underwent mastectomy comes to you with the bluish colored nodules in the upper limb. That is nothing but the classical complaint. The patient might have had lymphedema and that lymphedema usually happens after axillary dissection, can happen after axillary dissection or after radiotherapy, will now after 10 to 20 years, if there is a lymphedema, after 10 to 20 years, they will develop lymphangiosarcoma. So, lymphangiosarcoma, this syndrome is called as 𝗫𝗏-Trevis syndrome. This syndrome is called as 𝗫𝗏-Trevis syndrome. So, don't forget this point. It is called as 𝗫𝗏-Trevis syndrome. And breast cancer surgery has been done 10 years back. Patient comes to you with the raised cutaneous lesions in the upper limb. What is the likely causes? Lymphangiosarcoma. That is 𝗫𝗏-Trevis syndrome is the cause here. This is a straightforward image-based question. Chronic male smoker presented to hospital with the fever, malaise and lethargic symptoms. He is also complaining of hemoptysis in the early morning. He has lost 10 kg in the last 2 months. I don't want to read anything. I will directly go to the X-ray. From the X-ray, you can see cannonball mets. Cannonball mets are classically seen in this patient. Cannonball mets are most commonly coming from RCC, renal cell cancer, or it can come from seminoma. So, most of the metastasis will produce mets like a cannonball appearance. So, this is metastasis to lungs will be the better answer of this question. So, the answer for this question is metastasis, showing you cannonball appearance. See the cannonball, multiple cannonball in both the lungs. Okay. Which appendicular cancer is commonly associated with 𝗬𝗎𝗪𝗂𝗋 peritonei? See, I want you to know what is first of all PMP. This is known as 𝗬𝗎𝗪𝗂𝗋 peritonei. It is a completely new question for your exams. Definitely FMGE exams, this topic you would have not read. It's a total new question. Please understand, hereafter this question becomes a repeat question. Understand this concept. So, this is an abdomen cavity. The abdominal cavity is entirely lined by peritoneum. It is fully lined by peritoneum. Fully lined by peritoneum. So, the peritoneal lining is seen all over the abdominal cavity. That is full of peritoneal cavity, showing you this picture. So, now some tumors from the abdomen can spread to this peritoneum and it can produce peritoneal malignancy known as 𝗬𝗎𝗪𝗂𝗋 peritonei. So, peritoneum will secrete mucin like this. So, that mucin will be found all over the abdominal cavity. They will have mucinous ascites. So, this mucinous ascites is classical finding of these patients, mucinous ascites. So, when there is a mucinous ascites, you will have unilateral or ascites with a no shifting dullness may be there. Unilateral or absent shifting dullness may be present in these patients. So, but how does the peritoneum get the malignancy is a question. How does it get? The question is, most commonly it gets from an appendix neoplasm known as appendiceal mucinous tumors. Appendiceal mucinous neoplasm, when it ruptures, it causes this problem of 𝗬𝗎𝗪𝗂𝗋 peritonei. When it ruptures, it causes this problem. Number one, this is the most common cause. In females, ovarian mucinous neoplasm, that can rupture and cause the same problem. Also, very rarely, mucinous cancers, mucinous GIT cancers can also cause this problem. So, whatever it is, there will be mucin everywhere in the abdominal cavity, there will be mucin, and this is answer for this case. Which appendicular cancer is commonly associated means mucinous adenocancer. And these patients need a major surgery known as cytoreductive surgery. This is very well updated in Bailey and Lau. You can see a very beautiful image of this disease and surgery. That is why they have asked it this year. Cytoreductive surgery plus HIPEC is done for these patients. HIPEC is hyperthermic intraperitoneal chemotherapy. Hyperthermic intraperitoneal chemotherapy. We will pour chemotherapy into the abdominal cavity. That is called as HIPEC. We will pour, after removing many structures in the abdomen, we will pour the chemotherapy into the abdomen for 12 to 14 hours. This procedure extends for 12 to 14 hours. It's a major surgery, but the patients still have a bad prognosis. So, please remember, 𝗬𝗎𝗪𝗂𝗋 peritonei may be a future question for your exams. See, neonate is diagnosed with gastroschisis. So, this again a repeat question. What is the management of this case? Gastroschisis is a defect in the right iliac fossa with the umbilicus normally attached. See, this is normal umbilicus. Defect is in the RIF. Defect is to the right of umbilicus, and there is no covering membrane through which angry looking bowel comes out. So the bowel is coming out without a covering membrane. So in gastroschisis, no covering membrane. In omphalocele, you have covering membrane. Gastroschisis is very dangerous because it is associated with intestinal atresia. It is associated with intestinal atresia. Therefore, they have a poor prognosis. Compared to omphalocele, they have poor prognosis. And omphalocele can be slowly reduced with a 𝘂𝗷 bag because it is having a covering membrane. But gastroschisis needs immediate surgical wall closure and repair. Emergency surgery needed. Emergency surgery is needed for these patients. Emergency surgery is needed for gastroschisis. So please remember, usually gastroschisis defect is very small, not like omphalocele, a huge defect. Therefore, gastroschisis, immediate surgery and closure and repair is done. Okay, slowly putting it inside 𝘂𝗷 bag is done for omphalocele. Waiting for it to resolve slowly is also done for 𝗂𝗽𝗱𝗁𝗲 minor. 𝗂𝗽𝗱𝗁𝗲 minor, we can wait it to resolve. Okay, so we don't excise the gastroschisis, only we do surgical closure and repair. We should not excise any bowel unless there is an atresia. So best answer is A. A patient is posted for major surgery. What is the ideal INR value that should be? So please don't forget, INR is equal to prothrombin time of patient divided by prothrombin time of normal people, normal lab. So this is a comparative value. The normal value is usually 1. INR is normally 1. That is the correct value of INR. So if you measure, your INR will be normally 1. So when patient is posted for surgery, INR should be less than 1.5, then only you can do surgery. Otherwise, there will be bleeding. When INR is more than 1.5 and if you need to do surgery, what should I do? If it is an elective surgery, I will give injection vitamin K and reverse the INR. If it is an emergency surgery, what will I do? I should give fresh frozen plasma and take for surgery. So don't forget, if INR is less than 1.5, you can do surgery. More than 1.5, if it is elective surgery, vitamin K for 3 days will correct it. If it is an emergency surgery, FFB should be infused and take the patient for surgery. So what is the use of this INR? So should be taken for surgery when it is less than 1.5 is the correct answer. So there is INR monitoring essential. Monitoring of INR is done for whom? Patients on what therapy? Warfarin therapy. Warfarin therapy is given for patients who are having DVT. We should monitor the patients with INR. So those patients, the monitor value should be what? Value should be between 2 to 3 is ideal. When a patient with the DVT is managed by warfarin, maintain the INR between 2 to 3. That is the ideal value of INR in warfarin therapy patients. So don't forget warfarin therapy. What is the value needed? 2 to 3. What is the value needed for surgery? Less than 1.5. What is the most likely age to be classified as biliary atresia? Please don't forget, I already told you, this is extrahepatic biliary atresia. This is a disease in which we have discussed in our regular lectures. The bile duct inside the liver is normal, but outside the liver it has become atresia. There is no bile flowing out. So the patient therefore comes to you with a pathological jaundice. See, normally physiological jaundice is up to 14 days. So up to 14 days they will not have serious fear, and mostly we will tell the patient, don't worry, up to 2 weeks it is physiological. But when the jaundice is present for more than 14 days, the most common cause is what? It is neonatal hepatitis. That is the most common cause. But it is treatable cause, but dangerous cause. Second cause is what? Extrahepatic biliary atresia. So usually they come between 2 to 4 weeks, the patient comes to hospital. So immediately you should evaluate it and confirm there is biliary atresia and do an emergency surgery. What is it? Emergency procedure, what is done for this cases? It is 𝗂𝗽 procedure. So, 𝗂𝗽 procedure is a procedure in which I bring a bowel and anastomose with the liver so that the bile will be draining into the bowel and jaundice will resolve, known as porotoenterostomy. But treatment of choice is what? Treatment of choice is we have to plan soon for liver transplant. Don't forget this question. So, we have to plan for liver transplant at the earliest possible. So, initially you can do 𝗂𝗽 procedure. It is a time buying procedure. But as early as possible, we should do liver transplant for a biliary atresia. They come to you at 2 weeks. Extrahepatic biliary atresia comes to you at 2 weeks. So, 29th question I have already discussed. A newborn baby was brought to emergency with the bilious vomiting, abdominal distension. X-ray shows multiple air fluid levels. No air under diaphragm means there is no perforation. Baby is stable, but baby is continuously having vomiting. So, when I take an X-ray, if there is a single bubble appearance, it is congenital hypertrophic pyloric stenosis. When there is a double bubble, it is duodenal atresia. When there is triple bubble, it is jejunal atresia. When there are multiple bubbles, please remember that is midgut problem. That is either a malrotation or a valvulus. So, what is that investigation to confirm it is a malrotation of gut is? Investigation of choice for malrotation of gut is gastrographin study. You should make the baby drink a glass of gastrographin and take X-ray. Gastrographin study is done. So, the answer is A. We have to make the baby to drink a glass of gastrographin and do the test. It is gastrographin study. So, don't forget this is a very important point. 29th question is gastrographin study. The diagnosis is malrotation of gut. See, the problem happens in FMGE exams is every question they never give the diagnosis. They want you to know the clinical symptoms to make a diagnosis. So, therefore, I am telling you, first basic thing in FMGE exam preparation is know all the clinical diseases, their symptoms. After that, it is very easy. So, even in practice, when we are practicing also, the toughest step in practice is to diagnose a case. Once we diagnose a case, we know the investigation, management, everything is easy. But diagnosing a patient in a OP practice is like an exam. It is daily like an exam. So, if I am seeing 25 OP per day, the 25 OP is like an exam for me. So, therefore, as FMGE exam students, we expect you to diagnose the cases. If you diagnose the cases, don't worry, that is, you have treated the patient more than 75% just by making a correct diagnosis. So, the answer here is malrotation of gut. We have to do gastrographin study, and once it is a malrotation of gut, treatment of choice is what? 𝗏𝗪's procedure. It is 𝗏𝗪's procedure. Don't forget this point. The treatment of choice for this procedure is 𝗏𝗪's procedure. So, which of the following management is preferred in severe acute pancreatitis? See, there are acute pancreatitis. We can divide it into two types. One is mild cases and another one is severe case, in which there is BP, low, organ failure is present and all. We call them as severe. So, I don't know whether they gave any clue in this question, but there is no proper clue and the choices are also not properly recalled. But an acute pancreatitis, please understand, the question is related to nutrition and IV fluids and admission. Related question. This is from a paragraph in Balian law. From the paragraph, mild cases, you can give oral fluid and observe in the ward itself, general ward itself. You can observe these patients. Whereas severe cases, I should give IV fluids and I should shift them to SICU. In fact, for nutrition, they may need total parenteral nutrition. Mild cases, we can give nasogastric feeding. So, I don't know the exact choices, but from this question, I can tell if it is a severe case of acute pancreatitis, I will go for IV fluid and admit in SICU. That will be the better answer in this question. For 30th question, IV fluid and admit in SICU. A patient admitted in the hospital for a long time, following which patient developed swelling and pain in the left leg. So, no doubt it is DVT happening in the hospital. So, what is the investigation of choice for DVT? It is duplex scan. There is no difficult, it's not a difficult question, it's a simple question. For DVT, investigation of choice is duplex scan. Most common site of DVT is what? Calf veins, And what is the criteria to say it is DVT? That is known as Wells criteria. Wells modified criteria. Modified Wells criteria is used to diagnose DVT and also to diagnose pulmonary embolism. There is a criteria known as modified Wells criteria. Just know the name here. You can read in your regular class discussion, but this is duplex study for DVT. So this is a repeat question. Every year they are asking question from retrograde ureterogram. Retrograde ureterogram, RGU, is an investigation of choice for urethral stricture or injury. In a urethral stricture, I will put a tube through the penis and push the contrast back. If I am pushing the contrast back, I will find out two injuries. One is membranous urethral injury. Only two injuries, membranous urethra stricture, and another one is bulbar urethra stricture. So there are only two places I will usually get, but easily you can identify membranous injury is usually following a fracture pelvis. Bulbar urethral injury is usually following a straddle injury. It is usually follows a straddle injury, means putting the two leg into the cycle bar or putting in the manhole, that is known as straddle injury. So we can easily identify this by seeing the image, and this image is showing you the injury is in the bulbar urethra. So I hope you know the anatomy of urethras. This is bladder, this is prostate. Please don't forget prostate, prostatic urethra. Membranous urethra is the shortest urethra. Please remember, it is the shortest, thinnest. This is membranous. Then comes the bulbar urethra like this. Bulbar urethra, then comes penile urethra. So this is bulbar, this is membranous. So when there is an injury in this area, we call it as bulbar urethral stricture. In this area, we call it as membranous urethral stricture. See this picture explaining you the anatomy. Bladder, prostatic urethra, verumentanum, membranous urethra, bulbar urethra. So bulbar urethral injuries will be having stricture in this place. Membranous urethral will be having here. So now see the picture. So there is a stricture in this place. Therefore, it is a bulbar urethral stricture. Don't forget this point. Simple image based question, but it is too much for an FMGE exam. To identify the site of injury is too much for an FMGE exam. But please understand it is bulbar urethral injury. You can get the same question again in the next year. 40-year-old male who is having a pet dog in his home, he presented with right upper abdominal pain. On evaluation, there is a lockulated collection in the liver. Which of the following is the most likely organism implemented in this pathology? So this is a classical question on pet dog. So pet dog means what? It is a classically hydatid cyst. It is a microbiology question. The organism is Echinococcus granulosus. So Echinococcus granulosus most commonly affects liver. So it will go to the liver and form a hydatid cyst. So this is a question showing you loculated collection in the liver means what? Echinococcus granulosus causing a hydatid cyst of the liver. So 55 years old male underwent lateral pancreatico-jejunostomy. I hope you know the name of the procedure. This is a pancreatic duct which is fully opened out like this and removed the stones and stricture, and we brought a bowel and anastomosed with this like this. So this is a classical picture of bowel anastomosed like this. So this is the stomach, duodenum and jejunum. So just for understanding I am making this picture, and this is a connection made here. So it is a limb anastomosis. So we have cut this bowel and brought it up and anastomosed like a lateral pancreatico-jejunostomy. Can you tell me what is the name of this operation? This operation is known as modified Puesteaux operation. Modified Puesteaux operation. See, this is a very commonly done surgery by gastrosurgeons. I am telling you again here, for a lateral pancreatico-jejunostomy, you need not worry. This is not going to leak because it is an isolated limb. So now whatever you are going to eat is going to go through this way. So this food will be going like this way. So you can start on giving supplementary nutrition can be done via oral feeding itself. No need of TPN, because in pancreatitis, GIT is not affected. GIT is normal. So you can give normal oral feeding. So following a modified Puesteaux, you can give normal feeding via mouth. There is another question, that is following a Whipple's operation for cancer pancreas. Whipple's pancreatico-duodenectomy. So this question, please understand, it is a major surgery. In this surgery, we cannot start oral diet now itself. Therefore, we will start them on feeding jejunostomy. So for those patients, we will do feeding jejunostomy as a supplementary nutrition for Whipple's operation. So this is modified 𝑃𝗬. Oral feeding can be started. This is what we do in our practice. This is a practice-based question. A skin topic related to cancer penis known as condyloma acuminata. Condyloma acuminatum is a wart. It is a wart. It can be known as 𝗂𝗽𝗱𝗁𝗲 tumor if it is very big. 𝗂𝗽𝗱𝗁𝗲 tumor is a name given for giant condyloma lata. Such cases we should only go for excision, no doubt, because it is pre-malignant. I have to go for a excision and send it for biopsy. Usually it is seen in genital areas. Okay, therefore it should go for excision biopsy. Which of the following forms the lateral boundary of Hesselbach triangle? So don't forget, these are all very simple anatomy questions. So this is anterior superior iliac spine, this is pubic tubercle, this is inguinal ligament, and this is rectus abdominis muscle. So please don't forget, this is rectus abdominis muscle. And don't forget, this is external iliac artery, which gives the branch from external iliac artery. This is inferior epigastric artery, which is coming out. And the triangle you are showing here, the triangle is called as Hesselbach triangle. So please remember, Hesselbach triangle is bounded by three anatomy: rectus abdominis, inferior epigastric artery, and inguinal ligament. So inferior epigastric artery, rectus abdominis, and inguinal ligament. So what is the lateral boundary of Hesselbach triangle? What is the lateral boundary? Lateral boundary is inferior epigastric artery. So please remember this point, very important for your exam. So this is inferior epigastric artery, rectus abdominis, and inguinal ligament. It is a classical picture of Hesselbach triangle. So this 37th question is a question on radical neck node dissection and modified radical neck node dissection. So in radical neck node dissection, we remove level 1 to 5 nodes plus S submandibular gland plus parotid gland, not fully part of parotid gland. So the same is removed in modified radical neck node dissection. 1 to 5 nodes, submandibular glands, part of parotid glands, and also we remove SIS in R&D. That is spinal accessory nerve, internal jugular vein, and sternocleidomastoid. So in R&D, radical neck node dissection, spinal accessory nerve, internal jugular vein, and sternocleidomastoid is removed in radical node dissection. They are preserved in modified radical neck node dissection. So preserve SIS in MR&D. Please don't forget this point. So in MR&D, we have to preserve them. In R&D, we have to remove them. So in modified radical neck node dissection, which of the following structure is not preserved is submandibular gland is removed. Okay, that is a very important basic point. So there is a MEN1 related question. MEN1 syndrome, you all know very well, it is Wermer syndrome. It is again a pathology as well as surgery question. MEN1 Wermer syndrome will have P. What are the three P? Parathyroid adenoma. Parathyroid adenoma is seen in 100% all the patients. Pituitary tumor, that is prolactinoma. What else? One more P. That is a common cause of death. That is pancreas gastrinomas. Please remember, gastrinomas are the most common cause of death. Most common cause of death is pancreatic gastrinoma. So therefore, which is not included. Pheochromocytoma is a feature of MEN 2A and 2B. That's a simple question on MEN syndrome related question. I'm sure you all would have answered it correctly. 3P for MEN1. A patient arrives to emergency department with a severe maxillofacial injury and his airway is compromised. Immediate airway is needed. So Le-Fort injuries. Le-Fort injuries are nothing but maxillofacial injuries. Here orotracheal and nasotracheal should not be done. Please remember, are contraindicated in those cases. Le-Fort maxillofacial injuries, you should not try to put a orotracheal or nasotracheal. Ideal way of putting an airway is putting into a tracheostomy is the ideal. Because there is fully nasty area, this area is fully damaged, you should not try to put anything into the nose or mouth, we can cause more damage. So as of now, put a tracheostomy intubation and give the airway. Afterwards, we will decide about proper other management. So for maxillofacial injuries, tracheostomy is done. So the last question for discussion from surgery. So this repeat MCQ, PET scan is the investigation of choice for metastasis patients. Many cancers we do investigation of choice is PET. For doing that, we use a radioactive substance. What is that substance? It is 18-FDG is most commonly used. So most commonly used radioactive substance in PET CT is 18-fluorodeoxyglucose. It is a concept is the cancers which are having high Ki-67 index, or otherwise cancers which are growing very fast, they utilize more glucose, so that they have increased glucose uptake. So therefore, instead of glucose, we will give 18-FDG, which will show you the uptake on scan. So this will have false positive in whom false positive values are seen in diabetic patients, and in TB patients you can have false positivity can happen in PET scan. Please don't forget. So there are so many questions which are asked in FMGE exam. So these are some of the questions I got as a recollect. So I'm sure these questions may be again asked in the next exam. So please go through these questions again and again. I'm telling you, don't go through the questions again and again. Please go through the concepts again and again. The same concept you should repeat. That is more important. Okay. Thank you.